Hi, everyone. Today we're talking about physiology in the respiratory system, which means you should have already studied respiratory anatomy before taking on the challenge of respiratory physiology. This is a pretty complex topic, and at this level of anatomy and physiology, we're going to try to focus on just the essential pieces of respiratory physiology. First and foremost, we need to start with some basic definitions, and we're going to see these mentioned repeatedly throughout this lecture video. So, respiration really has two main parts to it. We are going to have external respiration and we're going to have internal respiration. And they are related and integrated together with the goal of being able to provide oxygen to the tissues and cells of our body. So in the case of external respiration, this is going to include all of the processes involved with exchanging oxygen and carbon dioxide between the blood and lungs and the external environment. So when we think about external respiration, we should kind of be thinking about breathing, moving air into our lungs in order to get that oxygen, and then moving air out of our lungs to get rid of CO2. So we can kind of divide up external respiration into two parts: pulmonary ventilation, which is just getting air in and out of the lungs, and alveolar ventilation, which is specifically getting the air into the alveoli of the lungs so that oxygen and carbon dioxide can diffuse across the respiratory epithelium and get into the blood. And then we have, the oxygen can get into the blood and the CO2 can move out into the alveolar space. And then we have internal respiration, which is going to be the process by which O2 moves out of the blood so that it can be absorbed by cells and tissues of the body. And we need to, of course, get the CO2 that's been generated by the cells in tissues and get that out of the interstitial fluid and into the blood so that we can get it into the lungs so that we can breathe it out. So some other associated vocabulary with respiration is, one word would be hypoxia. This means low oxygen, and that's going to constrain the metabolic activities of the area that doesn't have enough oxygen. And then anoxia is when the supply of oxygen is completely cut off. So these could come about due to not being able to get oxygen into our lungs or being able to absorb that oxygen across the respiratory epithelium. But another possibility is that damage from a stroke or a heart attack results in localized hypoxia or anoxia. So there's different ways that these things can come about, but the issue is the same in terms of whether or not there's enough oxygen. So how do we breathe? What's the mechanism of breathing? Well, as I said, pulmonary ventilation is how we get air in and out of the lungs. And that means we have to inspire and expire. We're going to move air into the lungs and we're going to move air out of the lungs. In order to move air into the lungs, we're going to contract the diaphragm and the external intercostal muscles. When you contract the diaphragm, it actually flattens out and that drops it towards the abdominal cavity. And when the external intercostal muscles contract, it lifts the ribs. And these two things are going to increase the size or volume of the thoracic cavity. And that's important because when you increase the volume of something, you decrease the pressure of the gas within. And I'll talk about that more in a second. So by decreasing the pressure inside the lungs, because we have increased the volume, that allows air to move into the lungs. On the other hand, if we want air to move out of the lungs, we want to increase the pressure inside, and we can do that by decreasing the volume of the thoracic cavity. So a really easy way to do that doesn't take a lot of effort, is simply to relax the diaphragm and the external intercostals, which will collapse the rib cage and move the diaphragm up towards the lungs decreasing the size of the thoracic cavity, increasing the pressure inside, forcing air out. So we consider this a mostly passive process since it simply requires us to relax our muscles. Now, if we're exercising or we have a higher demand on our respiration, we may need to engage with the internal intercostal muscles in this expiration process because they can help decrease the size of the thoracic cavity to increase that pressure for expiration as well. So over here, you can see our primary inspiratory muscles are the external intercostals right here. Deep to them would be the internals. And then there is that diaphragm here, and you can see it's pretty high, but upon contraction, it would drop lower. And then there are some accessory inspiratory muscles. So these are sort of synergists for the primaries. So things like the sternocleidomastoid can lift up on the clavicle and the manubrium of the sternum. The scalenes can lift up on those top ribs, and pectoralis minor and serratus anterior can also lift on the rib cage. So they're going to act as synergists to help expand the thoracic cavity as needed. Some things we need to remember about the lungs is from your study of respiratory anatomy. Remember that it is a continuous column of air from the pharynx to the alveoli, and a large part of that column is in the anatomic dead space, which just means the conducting portion of the respiratory system. So when we're moving air into the lungs, right, we want to get it into the alveoli. That's where gas exchange is going to happen. But all of the air can't be in the alveoli. A whole bunch of it is going to be in that anatomic dead space or in the column, in the trachea, in the bronchi, right, in your throat. And in those places, we're not getting gas exchange. That's why we call that the anatomic dead space. Also from AP1, remember that the lungs are within a sealed thoracic cavity. You learn that they have a pleura, a two-layer membrane around the lungs. So there's the parietal pleura that adheres to the wall of the thoracic cavity, and the visceral layer or the visceral pleura that's on the lungs with some fluid in between. So that's important because that helps maintain the lungs to be open so that we can get inspiration. And then I mentioned I was going to talk a little bit more about the relationship between pressure and volume. So that's known as Boyle's law. And Boyle's law says that the pressure of gas is inversely proportional to the volume. And when we say inversely proportional, what we mean is that as one goes up, the other goes down. So if we increase the volume, then we decrease the pressure. So let's take a look at that. So here are the lungs. When we want to inhale, if we want air to come into the lungs, we don't want there to be a lot of pressure inside the lungs. We want to make it really easy for air to move into the lungs. So we expand the thoracic cavity, we increase the volume. And as we increase the volume, that means we decrease the pressure inside the lungs, which makes it easy for air to flow in. On the other hand, if we want air to flow out, we want the pressure in the lungs to be higher than it is outside our bodies. So we shrink or contract the volume of the thoracic cavity, which increases the pressure inside the lungs, which allows the air to flow out or even forces the air to flow out because pressure outside the body is lower. And so the air will flow towards that lower pressure. That's Boyle's law, which is physics, but it's fine. It makes sense. You're okay with it. All right. So upon contraction of the diaphragm and external intercostal muscles, the volume in the lungs increases. What's the consequence of that? So if we increase the volume, that means the pressure will decrease. And if the pressure inside the lungs decreases, that means air will move into the lungs, and that's inspiration. So the pressure in the lungs decreases and inspiration results. So how do we measure the volume of air that we're moving in and out of the lungs? Well, we can use a machine called a spirometer to do that, and then a spirometer can generate a spirogram for us, and we can see a number of important pieces of information using a spirometer. So First important vocabulary word is tidal volume. That's the amount of air that moves in and out of your lungs during a single respiratory cycle under resting conditions. Vital capacity, on the other hand, is the maximum amount of air that you can move in or out of your lungs in a single respiratory cycle. Now, you know that if you're just breathing normally, if you take a breath in, you can then take in more breath, right? So you breathe in and then you're like, and you can really fill your lungs up. And then you can breathe out, but then you can breathe out even more. Try to empty your lungs all the way out. So taking in more air than you would normally, that's your inspiratory reserve volume, or the amount of air that you can breathe in over and above your normal tidal volume. And when you breathe out beyond your normal breathe out, like you force more air out, that is your expiratory reserve volume, which is the amount of air that you can voluntarily expel after you have completed a normal respiratory cycle. So you've just breathed out and then you blow out a little more air. Now, here's the thing. There's always going to be air in your lungs that you can't get out, and that's called the residual volume. So some of that air is always, some of the air that's in your lungs is always going to stay in there, which means if we wanted to calculate your entire lung capacity, like all the air that could fit in your lungs, we'd have to add the vital capacity to the residual volume. So let's take a look at a spirogram and see if it makes more sense in a picture than in just words. So this blue line right here represents tidal volume, right? Inspiring, expiring, inspiring, expiring. And it turns out that that's about our normal tidal volume is about 500 mils. So we breathe in and we breathe out about 500 mils with each breath. And that doesn't change for men or women. So that's kind of interesting. But something else is going to change between men and women. We'll get to that in a second. Now, if I breathe in just the normal amount, but then I sip in some more air as much as I can, that's my maximum inspiration, which would be my inspiratory reserve volume. So inspiratory reserve volume. We start at where our normal tidal volume would end, and then we go up from there. That's our IRV. And then we can breathe out, and anything from what I would normally breathe out and beyond will be my ERV, my expiratory reserve volume. So just looking at this picture again, this dark beige bar represents our tidal volume, the normal amount of air that moves in and out of our lungs when we're at rest, about 500 mils. But if we sip in more air, that's our IRV, or if we force out more air beyond our tidal volume, that's our ERV. But notice our residual volume is still there, even after we've blown out our expiratory reserve volume. So if we measure our inspiratory reserve volume, our tidal volume, and our expiratory reserve volume, all three added together is our vital capacity. Again, our vital capacity is the maximum amount of air that we can move in and out of our lungs in a single respiratory cycle. And it is the sum of the ERV, the tidal volume, which is VT, and the IRV. If we want to know our total lung capacity, though, we're going to have to add the residual volume to the vital capacity to get the total amount of air. And if we look over here at average lung volume, you can see it could be as much as 5,800 milliliters of air for a total lung capacity as measured by this spirometer device over here, where you breathe into it with your nose closed off so that no air is being lost or coming in through your nose. All right, so let's look at that another way. First, in this chart, there is our tidal volume, VT. And you can see in both men and women, it's about 500 mils that we're moving in and out as our tidal volume. But when you start to look at IRV and ERV, you start to see some pretty big differences. Men have a much larger IRV and ERV relative to women. Now, again, these are averages. Some women will have higher ones than some men, but as a general rule, statistically speaking, males have larger IRVs and ERVs, which means they are also going to have higher overall total lung capacity. Notice the residual volume. It is men have a larger residual volume, but the difference is smaller here, right? The big difference is here in the IRV and the ERV. If you look at how that corresponds to vital capacity, we're at 3,100 mils for females, 4,800 for males. Total inspiratory capacity, 3,800 versus 2,400. And so, that says a lot about how much oxygen males are going to be able to move around out to their, say, muscles when needed relative to females. But again, on average, you might remember from AP1 that women have lower density of muscle tissue than men. So maybe the difference here simply represents a difference in need for perfusion of oxygen. All right, some formulas over here, just as a reminder. Vital capacity is ERV plus tidal volume plus IRV, and that will give us the maximum amount of air we can move in or out. If you want inspiratory capacity, just how much can you breathe in, that's going to be your tidal volume plus your inspiratory reserve volume. So just how much could you inhale after you've normally expired. And then a new one here, and it's not hard or complicated, but it's important to know, is respiratory minute volume. How much air can we move in a minute in and out of our lungs? So that is going to be our respiratory rate, which we use the letter F to represent. So how many breaths per minute times our tidal volume will give us our VE, which is respiratory minute volume. So what's our tidal volume? 500 mils, we know because it says right here in this chart. And then how many breaths are we taking? Let's say it's 12 to 16 on average when we're just kind of quietly breathing at rest. That would give us our VE. And if we have, let's see, if we were breathing, if our respiratory rate was 12 and our tidal volume was 500, then that would give us 6,000 milliliters per minute of air moved in and out of our lungs, or 6,000 milliliters is equal to 6 liters. So 6 liters of air in and out of our lungs on average every minute when we're just resting. Okay, so what about the gas exchange part though? So again, external respiration is how we get the blood, the exchange of gases between blood and the external environment, air, and external respiration, the movement of air into the lungs and into the alveolar space is going to be really important for that. But we then also have to get it across that blood-air barrier from the alveolar airspace into the alveolar capillary. So that's all part of external respiration. But then internal respiration is, okay, how do we get that exchange of gases between the blood and the tissues? And again, I'm just reminding you that hypoxia and anoxia are important here because they are going to describe situations when we either don't have enough oxygen or no oxygen at all. So these images, if I can just blow this up a little bit, this is just a visual of external respiration, including pulmonary ventilation, where we are moving oxygen and carbon dioxide across the respiratory epithelium, versus internal respiration, where we're going to be moving oxygen out of the blood and into the surrounding cells and tissues, and carbon dioxide out of the tissues and cells and into the blood. So just a little bit, different thing there. So make sure you remember the difference between external and internal respiration. So one thing we like to talk about is partial pressures, which is sometimes a little scary for students, but it shouldn't be. Partial pressure is just the pressure exerted by a single gas in a mixture of gases. So instead of looking at the overall pressure of the gas, which is what we talked about when we were talking about Boyle's law and the pressure in the lungs or outside the lungs as a way of either moving air in or out, now we're not interested in the pressure of air with all the different gases in it. when we talk about partial pressures, we're interested in the particular pressure of each gas within that mixture. So that's why we call it a partial pressure. So what we're seeing here, for example, in external respiration, we have deoxygenated blood coming from the right side of the heart into the lungs, right? So the partial pressure of oxygen is pretty low because it's deoxygenated. So it's here at 40. And the partial pressure of CO2 is a little high because we've picked up carbon dioxide. So it's riding at about 45. So as as this blood goes past the alveolus and gets right close to this airspace inside the alveolus, right, the partial pressure of oxygen is going to be really high because we just breathed in. So it's going to be, say, around 100. And that is going to mean that it's going to be easy for oxygen to diffuse from an area of high pressure to an area of low pressure for oxygen. Meanwhile, inside the alveolus, the partial pressure of carbon dioxide is 40, which you might be thinking, well, that's not a whole lot lower. It's not a whole lot lower, but it's low enough, and that allows for carbon dioxide to diffuse out of the blood and into the alveolus. So we get that gas exchange due to the differences in partial pressures. Now, watch out for this diagram because look, there's an error here. I circled it for you. These numbers are exactly the same. That is not correct. Once oxygen from the lungs has diffused into the pulmonary capillaries, we are going to see the partial pressure of oxygen go up to around 100, and the partial pressure of carbon dioxide will decrease from 45 to about 40. So I think if you have a recent edition of the textbook that this image has been corrected in the textbook. I think it's just this version in my PowerPoint that hasn't been updated by the publisher yet. So I pointed it out to you. Now, if we look at partial pressures in internal respiration, we're going to see sort of the opposite, right? Because now this blood from the lungs is going to go to the left side of the heart. It's all high in oxygen, low in carbon dioxide. It's going to go to the heart, and the heart is going to pump it out to the tissues of the body. So as this blood arrives at the tissues, we're going to see high oxygen. It's dropped a little bit. Some of that oxygen has already diffused out, but we're still riding pretty high at 95. And our carbon dioxide is still low at 40, which means as we approach the tissues in a capillary, the partial pressure of oxygen is going to allow it to diffuse out of the capillary from where it's high to where it's low, because out here in the cells and tissues in the interstitial space, the partial pressure of oxygen is low because it's been used up. So it's only at 40. So we're moving down its pressure gradient. On the other hand, because of waste production, our partial pressure of carbon dioxide is pretty high in the interstitial space. It's at 45, which is high enough to drive the pressure gradient towards the capillary for CO2. So CO2 will exit the interstitial space and move into the capillaries. So this is how partial pressures is important to the movement of gases in your body. And partial pressures and this movement is something known as Dalton's law. Again, something else to do with physics. So the exchange of gases occurring in the lungs between the atmosphere and the blood is known as, that would be external respiration. But if we replace this and we say something like between the interstitial fluid or the cells and tissues and the capillaries, then it would be internal respiration. Okay, so kind of summing up what I said just on the 2 slides ago is that external respiration, the diffusion is based on the partial pressures of oxygen and carbon dioxide. And we're going to see the exact same thing with internal respiration, as I showed you in that picture on that previous slide. So it's the same principle. We're going to have diffusion due to partial pressure differences. We basically have pressure gradients that allow those gases to diffuse down their pressure gradients. Also, just important to remind ourselves, because you could be asked, how are we moving carbon dioxide and oxygen in the blood? Well, oxygen, you already know, is carried by hemoglobin in red blood cells. And when hemoglobin has oxygen bound to its iron molecules, we call it oxyhemoglobin. And the higher pressure in the atmosphere allows for oxygen to diffuse into the blood. So that's all we get. Again, we have the right partial pressure differences. Carbon dioxide, on the other hand, can be carried in the blood 3 different ways. It can be carried by hemoglobin. Seems odd, but it's true. It's also capable of just dissolving in plasma because there are buffer systems in the plasma. And so carbon dioxide is really good at dissolving in water and forming carbonic acid, which then can combine with some other molecules into this buffering system. So it's relatively easy for carbon dioxide to be absorbed by the blood plasma. And then it can also be carried inside red blood cells as part of bicarbonate ions. So 3 different ways that CO2 can be carried in the blood so that it can diffuse out into the alveolar space and ultimately be expired out of the body. Whereas oxygen really is going to be carried pretty much exclusively by hemoglobin in red blood cells. Okay, so that might beg the question, how does your brain or nervous system regulate or control breathing? Well, it does that mostly by the respiratory control center that's located in the medulla oblongata, which you might remember from AP1 is part of the brain stem. So our normal respiratory rate is about 12 to 20 ventilations per minute. And again, that can be adjusted or regulated by these centers in the brain. Messages can be sent to the diaphragm and the external intercostals to increase the rate of breathing. And those messages may come in response to sensors. And some of those sensors include stretch receptors, which are inside the lungs that help detect excess stretch because we don't want to overstretch lung tissue. There's a lot of elastic fibers in the lung tissue, and we don't want to overstretch and damage those elastic fibers because if we damage the elastic fibers, the lungs will lose their recoil ability, and that's essential to how the lungs function, to move air out of the lungs. And also we have chemoreceptors like baroreceptors in your blood vessels that are very sensitive to CO2. So very small increases in CO2 can be detected by these chemoreceptors, and they will respond by having the respiratory control center increase your respiration rate. This is one of the reasons why it's pretty hard to hold your breath for more than a minute. You can train yourself by being better at taking in oxygen so that there's more available so that you can hold your breath for a longer period of time. Ironically, maybe we have chemoreceptors for oxygen, but they're not very sensitive. Your oxygen levels have to decrease a lot, like down to like 60 millimeters of mercury, if I recall, in order for them to instigate a response in the respiratory control center. So here's a picture of the medulla oblongata. You can see there's a number of centers that together make up the respiratory centers that help regulate breathing. They are going to be important for contraction and relaxation of the diaphragm. They are going to establish the pace or rate of respiration, and they can also modify activity in response to chemical and pressure signals from some of those sensors that I just talked about. So which of the following parts of the brain controls respiration rates? And hopefully when you read through this list, you're like, only one of these makes sense, and it's the brainstem. Although I will tell you that the hypothalamus does have a higher center, and essentially like normal respiratory cycles could continue even if the brainstem superior to the pons has been severely damaged though. So while they can alter the actions of the respiratory centers in the brainstem, ultimately the brainstem centers are capable of maintaining respiration on their own without the diencephalon. So that's just kind of an interesting little piece for anybody that has a extra interest in neuroscience. All right, and then that brings us to the disorders of the respiratory system. So kind of going back and thinking about the anatomy of the respiratory system, you might have come across in your book discussions about how viruses can affect the respiratory system. Sinusitis, tonsillitis, laryngitis, these are all upper respiratory issues, usually connected to infections from microorganisms. When we think about the lower respiratory system, so we're getting into the lungs here, we're talking about the bronchi and deeper into the lung tissue. We can think about acute bronchitis, pneumonia, tuberculosis, which used to be called consumption. TB is a really tough one. It's very hard to treat because the antibiotics have to be taken multiple times a day for, I think, as much as a year. And so patient compliance with that can be challenging. We are also seeing antibiotic resistant strains of TB. So that's really challenging healthcare systems in places where TB has erupted. And we have a number of states and communities that have pretty large case numbers of TB in the United States, often associated with people who have come from a country where TB is more common, and then they create a TB sort of epidemic or outbreak where they live here. So I think there's currently one in Alaska. There's one in Wisconsin right now. And again, they're very slow to treat because the treatment process is so long. So you can go down the Google rabbit hole on that if you like. You also really can't talk about respiratory system disorders without talking about restrictive and obstructive pulmonary disorders. So restrictive pulmonary disorders would include things like pulmonary fibrosis, think impacts from asbestos and other particulate matter that build up in the connective tissue of the lungs, and that reduces compliance. It makes it really hard for the lungs to expand, so inspiration is going to be more difficult. Obstructive pulmonary disorders, or COPD, will include things like chronic bronchitis and asthma and emphysema. The issue here is that the airways themselves are restricted, which makes it very easy to it makes it very difficult to get air in. So with emphysema, we also see increased compliance. That means they expand, but that's actually a problem because there's too much, the surface area is decreased as a result of the increased compliance. So there's less surface area for diffusion of gases. So it makes it harder to get a necessary or needed amount of oxygen into across the respiratory epithelium and into the blood. And then with lung cancer, lung cancer is a real stinker of a cancer. They tend to be quite aggressive. They are usually in the epithelial cells that line the conducting passageways. They could also be in the epithelial cells of mucus glands in the respiratory system as well. Typically, you won't have signs or symptoms of lung cancer until the tumors are large enough that they actually start to restrict airflow or compress on adjacent structures, which will lead to things like pain or shortness of breath or like coughing or wheezing. Most lung cancers are related to smoking, up to 90% of lung cancers, but it is possible to develop lung cancer that's not connected to smoking. Even secondary exposure to smoking can be just as risky. If the tumor is isolated in the lung and hasn't metastasized elsewhere, we might be able to do a pneumonectomy and remove a chunk of lung with the tumor. And it's not a small surgery. That's a pretty tough one to go through. But hey, if you can get rid of the tumor, that's a great thing. So you can also read more about what happens, like how smoking, for example, can cause neoplasias and anaplasias in the lung. And that's really basically like how the chemicals in the cigarettes will damage the cells and then start to change their shape and then start to change their arrangement and organization until ultimately you have a tumor. And there's also a pretty cool graph in your book that shows how your lungs respond if you stop smoking. So you can compare people that have never smoked with people that have stopped smoking at different points in their lifetime. And the answer is it's best to have never smoked at all. But not smoking starting now is better than continuing to smoke. Like your lungs get better. They can get a lot better if you stop smoking. And I think that's it for me. I would just point out one more thing, that in your textbook, there is a great spirogram like the one I showed you in this PowerPoint, but it's blank and it has lots of numbers so you can label all the different key vocabulary words. And I think that would be super helpful for you in getting ready to take a unit test on this topic.